Welcome to this short lecture on experimental single case designs. Why design about single cases? Well, we know that if we want to ask a question about treatment effectiveness or efficacy, for example, what we're wanting to do is try to recruit as many participants as we can from a population that share the characteristics. So we want people who are as similar as each other as possible. And then we want to randomly allocate them to two groups. But what if the people who could benefit from the intervention you're wanting to test are not a homogeneous group? What if they're all incredibly different to each other? And in many of our populations that we work with, it can often be really difficult to get large samples of individuals who share characteristics. So perhaps people who've had amyotrophic lateral sclerosis, people with cerebral palsy who have a particular type of cerebral palsy and particular communication issues, for example. It may be really hard to get them at the similar age, with a similar educational background and a similar cultural group, etc. And in fact, what you may have is one, two, or three individuals who share a problem, such as a communication issue, but are very different from each other. Single case designs allow you to study the effects of an intervention on a single individual, or maybe just a few individual people or cases. Let's take an example. Okay, let's think about treating stuttering using a method that was found to be very effective many years ago called delayed auditory feedback. That is, a person talks, but as they're talking, they can hear, wearing a headset similar to the one I've got, their voice being fed back to them at a very short delay. And for some reason, for people who are stutterers, this actually resulted in fluent speech. And so in an experimental single case design, what you would do is you would observe the person over a number of sessions. So here at the bottom are the sessions, which this represents data points over time or time. And here you would plot, first time I observed the person, I might have taken a sample from the individual and they were presenting with 30 syllable stutters a minute. Syllables stuttered a minute. At the second time of observation, which may have been the next day, it was even higher, and on the third day it was higher still. Okay. And then clinically what you would do is you take your baseline and then you would apply an intervention. Now in this case the intervention is wearing the headset and getting the delayed feedback of your own speech. And wow, you can see that treatment looks incredibly effective, up from 50 down to 20, and then it continues to go down with practice. So it really looks like this treatment is very effective. The issue is, who knows, maybe in between time the person just got a little bit more savvy about his own speech and started to do exercise, or maybe was less stressed in his work situation. There could have been a whole lot of things that were going on for this person that actually were the cause for the change or the reduction in his stuttering. So how do you figure out, without a large group and a control group, whether or not it was the intervention? Well, with this type of design, what you do is you reintroduce your baseline conditions. That is, in this situation, you take away the delayed auditory feedback. And you can see, actually, whatever else was going on in this person's life, it doesn't seem to be what's causing the effect. It is actually when I reintroduce the treatment, when I take away the treatment, I can see that the person's performance or high percentage of syllable stutters goes up again. And it's coming down a little bit, but it's still the same as the first baseline. Now this is baseline, phase A, treatment, phase B, and baseline. So this is what would be considered a single case experiment, because I can demonstrate that it's only when treatment is introduced that I get an effect. And when I take away that treatment, then I get the return to baseline. Now clinically, You don't want to leave the person in a similar problem condition as when you found them. You actually want to leave them doing well. So what we tend to do is we reintroduce the intervention. And this strengthens the design because you've repeated that the demonstration that it actually is when you introduce the delayed auditory feedback that you actually get the reduction in stuttering. So this is known as an ABAB design, and it is the basic experimental single case design. Every other design, which is called an experimental single case design, is a variation of this, but it has the core components of comparing an intervention phase to a baseline phase and demonstrating that it is only when treatment is in effect that you get the desired outcome. Now, one problem with the reversal design is most of the interventions that we have in speech pathology, for example, are ones where we actually want a person to learn. So if this was an intervention which was not the delayed auditory feedback, but perhaps teaching the person to control their fluency through cognitive approaches, you actually may not see return to baseline because they've actually learnt something. And that's a good thing. But the problem is that you're then, again, not sure whether or not it was your intervention. So to deal with this, we use a variation of this reversal design or the ABAB design. So we're trying to vary the basic design so that we actually can demonstrate learning, but also demonstrate that it was the intervention that caused it. So let's take three individuals who are very different from each other, John, Mary, and Ibram. And they're different ages, they're different genders, and they're different cultures, and they may have other differences. So they're not very good candidates for a group because they're so different. And also it may be really hard to find enough participants who have the same problem that they have, which in this case is very delayed language. So how can we determine if an intervention of modelling two-word combinations in a scripted play routine can increase these children's production of spontaneous two-word combinations? How can we do that without using a randomised controlled design study, for example? Well, let's take the basic notion of a baseline. So here we have our three children, John, Mary, and Ibram. Okay, and we're taking baselines of their language production, and we're finding that, you know what, they're mostly either not talking or they're just using single words. They're not doing two-word combinations. So we've got a baseline for each of them. 3 sessions is usually a good idea. You can't see number 3, but there is a third session in there. Okay, now what we do is, instead of introducing intervention across all 3 participants, we stagger our intervention. So we introduce it for John, and we continue until it's pretty clear that John is getting better. He's actually doing 2 more two-word combinations. So you can see that he's gone from 0 to 1 to 0, and he's now got 3, 2, and then up to 5 two-word combinations when we introduced our intervention. We didn't introduce intervention for Mary or Ibram. So I've got things around the wrong way. This should be, anyway, it doesn't matter. But we didn't introduce intervention for the other 2. Okay? We continued them into baseline. So you can see they haven't improved because they haven't had the intervention. At least that's what it's looking like. All right. So now we're going to introduce intervention for Mary, our second participant. So we've continued it with the first participant, and he's going along nicely. He's staying at a nice high frequency of two-word combinations. And you can see with Mary, hers is starting to increase as well. Now with John, we've kept him in baseline because we still want to be sure that it's the intervention and not something else that's resulting in the change. And then finally, we introduce intervention for our final participant, in this case, John. So as you can see, in this multiple baseline design, that's 3 baselines, where we stagger intervention and we keep our second and third participants in baseline until we can demonstrate treatment effects for participant 1, and then we do the same across participant 2 and then 3. You can see and be fairly convinced that it's not just general maturation or other things going on, and there could be lots of different things going on in these children's lives, but it's the intervention that's having the effect, because maturation has had a chance to have its effect if it's going to. So this is a very useful design in order to demonstrate learning. Now, a variation of this is you may have just one participant, but the multiple baseline, instead of being across individuals, is across behaviours that you're wanting to teach. So for Ibram, we're wanting to teach him 3 different types of 2-word combinations. And it's exactly the same principle. We do a baseline across the 3 behaviours of interest. We stagger intervention, so we introduce it for agent plus action, but we keep action plus object and attribute plus entity in baseline. Then once we see an effect happening for the first behaviour, we then introduce it for the second, and the same thing. Once we see an improvement, then we introduce it for the third. And so, again, you're seeing treatment effects. Another variation is to have it across settings. So again, we have Ibram, but this time we're going to teach him different 2-word combinations, but we're going to teach him in the clinic, we're going to teach him at home, and we're going to teach him in the school. And we're going to see whether or not he learns these behaviours across different sessions. Now, obviously, there are some behaviours where that will generalise across settings. So you have to be careful that the behaviour that you're choosing is one that is not going to automatically generalise to a different setting. So you're really trying to design a study where you can keep the baselines fairly independent of each other. The other thing that we can do is add a generalisation session. So we could conduct all of these sessions across our 3 participants in a clinic, and then we might every now and then have one session where we move into the home situation just to see whether or not in an individual variation or a specific variation in an individual session where we do get some generalisation. And sometimes this is done by having somebody else do the intervention, particularly parents. So we as a clinician might be doing most of the sessions, but every now and then we might say, okay, Mum or Dad, you come in and you have a go, and we'll see if it will generalise to you. The other thing that we might add is some follow-up to see whether or not after we stop the intervention and just do a measure of the child's performance, kind of return to baseline without us doing intervention, whether they maintain the improvement in the behaviour of interest. So there are many variations to the simple ABAB design, such as multiple baseline across participants, behaviours and settings. That's one type. So multiple baseline tends to be across those 3 areas. There are other experimental single case designs. In fact, there are numerous ones. You could do your multiple baseline but using probes. So instead of every single day assessing the dependent variable, you may just do 3 and then come back again just before you implement intervention, so that you don't have a child showing up for sessions when actually nothing much is happening other than you doing some observation. So you'd be guided by what's practical and also what's ethical. Here's what's known as an alternating treatments design. So here what you're doing is, instead of having a no treatment, you might have 2 interventions, but you're not sure which is more effective than the other. And so again, as long as you can keep them quite separate, you might have the same child or even the same 2 or 3 children where you're actually trying different interventions. Okay? And one way of doing this is, this could be child 1 and I intervene teaching a particular set of vocabulary using just speech intervention. And then for this child, I might have a different set of vocabulary that I teach using speech and sign. So they're different interventions, and I find that one actually is more effective. They both result in change, but they're both effective. Now, the issue with this is that you can add a baseline, which makes it stronger, so you'd have a no treatment in phase here. Or you can say, look, we've already demonstrated in previous research that this is an effective intervention, and anything that could impact on one intervention can impact on the other that isn't. So any confounds are equally can equally be applied to these interventions. So you may not need a baseline condition. In fact, one intervention is acting a bit like a baseline to the other. If there is only one or a few participants, how can you test for the effectiveness of the intervention? And this is the question that people often ask. How do you know? Is it just by looking at the graph? Well, yes, but there are particular things that we look for. There's intervention changing the trend in the behaviour, the size of the change, and whether or not you're reducing the amount of variability in the behaviour. So if we look at trend, here we can see that with the intervention, the behaviour of interest is improving. That's your trend. Is it going up or is it coming down? Then you have the size of the change. So for Mary, she's gone for not doing any to a jump. Okay, so she's now producing a noticeable difference. Okay, so that's your effect size, and you're wanting to see changes in trend and the amount of change or an effect size across all. And then there's the issue of whether or not you're reducing variability. Okay, so here we didn't have a lot of variability to start with, but sometimes you can get lots and lots of variability, but with intervention it smooths out. Okay, and these are all patterns or features that you're looking for that help you feel more confident that yes, it was the intervention that was having an effect, and actually it was a really good effect. It was clinically significant. And these designs, because they are focused on the individual, tell you much more about clinical significance than sometimes group designs where there are lots of participants and statistical effectiveness is demonstrated, but the size of effect might be quite small. Okay, so same sort of thing. You're looking for trend. Is it going up overall? What's the size of the change? Okay, and is there a reduction in variability? Now, you can use statistics to help you, particularly where you've got data where there is lots of variability. Sometimes it's not as clear. So here's an example again of an ABAB design. And there are different ways or different statistics to look at whether or not you are getting treatment effects. Now, there's a measure called percent of non-overlapping data, and that is looking at the number of data points that overlap between your baseline and your intervention phase. So here we've got 2 data points. Actually 3 if we look at this one. We've got 3 data points out of 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So we've got 3 data points that overlap and 7 that don't. So the difference between these two would be 70%. Okay, so 70% non-overlapping data points, which would be quite a good effect size. And you could do the same for across the whole experiment. So in summary, experimental single case designs are used when it's difficult to obtain homogeneous or large samples of individuals, or when your question really is about treatment effectiveness, about one or a few individuals, when you really just want to know, is this intervention effective and how can I demonstrate that in a way that demonstrates experimental rigour. Now, the thing is that there isn't a control group, but that doesn't mean to say that there is no control in these designs. And that's a mistake that people often make. They fail to see a control group and then they say, well, it's a poor design because there isn't one. But actually the participants are acting as their own controls. So there is control and it is a rigorous way to do it. As with other treatment studies, the independent variable is the treatment or the intervention, and the dependent variable is the behaviour that you wish to change. And in a study where there may be more than one measure taken, the dependent variable of interest, or that's being tested, is the one or ones that are plotted on your graph. Treatment effects are demonstrated when improvement occurs only under your treatment conditions. They don't occur during baseline, or they are much more, it's much more dampened down effect, if you like. In reversal designs, such as ABAB, removal of the intervention results in a return to baseline performance. In a multiple baseline design, improvement is demonstrated only when the intervention, which has been staggered across the baselines, has been implemented. And these designs are considered level 3-2 on the NH&MRC hierarchy of evidence. So they're not as high as the randomised controlled trials, but in some situations they may be more appropriate. If they're well designed, and just because they're a level 3-2 doesn't mean to say they're well designed, so then you'd have to do a critical appraisal. But if they are well designed, they are very strong in demonstrating internal validity, that is, treatment effectiveness. But they require systematic replication across participants with various characteristics, or across settings, or across behaviours, beyond the multiple baseline, for example. But you need to do a number of studies systematically to provide evidence of generalisation. So they're not strong on generalisation, but they are strong on internal validity. So thank you very much.